it's time to start our webinar. I hope all of you can hear me. I'm your host, Caroline, and our live event today will be conducted by Dr. Nataliya Kushniruk, who is a reproductive medicine and genetics specialist at FertiCare Prague, which is located in the Czech Republic. She will start with a presentation on implantation window and uterine lining in IVF programs with donor eggs, and Dr. Nataliya's presentation will take approximately 20 to 25 minutes, and then our Q&A session will follow right after. And let me remind you that you can type in all of your questions in the chat section, and all of them will be published one by one and answered then by Dr. Nataliya, which you can already see, I believe. And of course, let me remind you again that this live event is being recorded and you will have a chance to watch it again tomorrow on our website. And you can take a look at the link to this webinar in the chat section, sorry. And Dr. Nataliya, are you ready to begin?
Yes, hello. Good evening to everybody.
Perfect.
So
Thank
let's
you.
start our presentation and webinar today. We are talking about IVF egg donation program and implantation window and everything related to the success rate of the IVF egg donation programs. First of all, let's say that we have definite requirements in the Czech Republic regarding to the egg donation program. Main requirements for intended mothers or ladies. They should be under 49 years at the day of embryo transfer. It means 48 years plus 364 days. They should not have serious health-related complications. So you should be able to carry pregnancy, because very important to carry pregnancy as long as possible, and ideally till the normal gestational term for delivery, like 37 full weeks. It means 37 plus 6 days, till the 40 weeks of gestation plus 7 days. So let's say 38 till 41. And definitely when we are talking about embryo transfer, when we are talking about possible complication during pregnancy, we should mention the body mass index. We cannot offer the IVF program, even the egg donation program, for a bit overweight ladies whose body mass index will be over 35. And when we return back to the health of the intended mother, we're interested in some kind of tests you may see here. And on some extent, these kind of tests and the health status of intended mother will affect in the future not only the implantation window and the possibility to become pregnant, but also the possibility to carry pregnancy. And on some extent, it will be our success with the good placentation. When we are talking about implantation, we are interested in good placentation. And from good placentation depends the growth and development of the future baby. It means of the fetus. You probably heard about such kinds of pathology like intrauterine growth retardation syndrome. And it may be from primary or so-called placentation insufficiency that happened from the very beginning, from the first steps of placentation, that starts from the 8th week of gestation and takes from 16th week of gestation, and then placenta development till the full 36, 37 weeks. And the secondary, let's say, placenta-related problems like secondary placental insufficiency, it may be a bit different cause, but anyway afflicted by vessels, by uterine flow, everything, all these components are collecting together, and definitely it may be the reflection on some extent of the general health status. So when you're thinking about pregnancy, and does not matter even with the egg donated, with the egg donation, it means that you should be ready not only for the IVF program, but as well for the carrying pregnancy. Here you may see the list of exams of intended father. On one hand, there is no direct correlation. It may seem that there is no direct correlation on the health status of the intended father. Anyway, it's not true, because we are, with the help of these, let's say, general health, we're interested mostly about, we're mostly interested in the sperm quality. And when we're talking about the poor sperm quality, or some sort of deviations in sperm, or for example, high DNA fragmentation of sperm, it means that sperm is not good for, let's say, to develop a good quality embryo. It may lead not only for the direct implantation failure, but also in the future it may lead to miscarriage rate, to some sort increased percentage of malformations, on increased sort of rate of stillbirths, and so on and so forth. So generally speaking, we're interested in both good quality of intended father, a good health quality of intended mother, and definitely we're interested in good quality embryos. I will shortly remind you how the whole process of egg donation is working. Now we are mostly talking about the distant works with patients, so you should not be from the state where the clinic is located. You may start working in your country, and then you will just come for embryo transfer, or your partner will come to produce his sperm sample, fresh sperm sample, or he may come early to produce frozen sperm sample, and when we have sperm material, the program will be going on. The most important part and the complexity of the egg donation programs related with the synchronization of the menstrual cycle and the preparation of, on the one hand, we are talking about egg donors. It means we need to culture, we need to prepare, we need to enable the growth of follicles, and thus eggs inside the follicles. And on the other hand, we are interested in perfectly synchronized, good quality endometrium of intended mother. If there is no good endometrium, receptive, with good thickness, with good signs, there is this soil in which we predict that your embryos, not our, but your embryos will be developing in the future. And let's say that, as I told widely before, so the effectiveness of the egg donation program is keen on embryo quality. Embryo quality consists of two parts: good quality of eggs and good quality of sperm. Good quality of eggs, we presume it should be good because egg donors are young ladies. They are between 18 and 34 years. They're healthy. So they're with good ovarian reserve, and there is no actual reasons to have bad quality eggs. The percentage of possible genetic pathology in their eggs is relatively low. When we're talking about future process like carrying of pregnancy, probably you've heard about several checkup or so-called genetic checkups during pregnancy. And when we're doing all these checkups, there is a limit. Ladies divided into two major groups, under 35 and over 35 years. Why it's happened? Because under 35 years, there is a small percentage of possible genetic deviation inside the oocyte or inside eggs. That's why all our egg donors are under 34. It means that we may presume that egg quality will be good. The next item is endometrium quality and receptivity. This item related to intended mothers. And by means of endometrial quality, we have several sources to evaluate the endometrium quality. It should not be uterine pathology, intrauterine pathology. It should not be any kind of congenital malformations. The endometrium quality should be thick enough, over 7.5 millimeters in the middle of the menstrual cycle, in pre-ovulatory phase of the menstrual cycle. We can measure it with the help of the ultrasound systems. Mostly in all clinics, we routinely use the two-dimensional ultrasound. And with the help of two-dimensional ultrasound, we can evaluate the thickness of endometrium. We can evaluate as well the paternity of endometrium. It should be in the middle of the cycle, trilaminar. It should be thick enough, trilaminar, it means good looking. It should not be abnormalities inside. It means no polyps, no fibroids, submucose, and so on and so forth. So in this case, we may presume that the endometrium is of the good quality. But sometimes it may happen that some patients have very good, nicely looking endometrium due to two-dimensional ultrasound. Unfortunately, one embryo transfer by other without any improvement. And we need to find the matter why did it happen. So the endometrium paternity and endometrium appearance or endometrium morphology, it's not the only thing we're looking or we're interested in. It means that we're interested as well in endometrium receptivity. There are two different types of receptors inside the uterine cavity on the surface of the endometrium or epithelium. They are supervised, if it's possible to use this term, by estrogens and progesterones, by both most significant steroid hormones inside the uterus. And if the concentration of estrogens and progesterone hormones are good enough, it means that the endometrium may be ready to percept the embryo. And I will show you, here is a picture. On this picture, you may see, as I told you, it's two-dimensional ultrasound scan. You may see here it's a mice point, one layer and a second layer. And here you may see a stripe inside, so it's trilaminar. The thickness of this endometrium here you may see it's 9.7 millimeters. It's also good. Here you may see as well not only the uterine cavity and the uterus, here you may see the cervix. And here you may see, as I pointed, there is some sort of mucus inside the cervical channel. It means that there is a good concentration. It's an ultrasound sign to some extent of pre-ovulatory phase. And you may see here inside the stripe of mucus that shows that this lady really had good concentration of estrogens inside her body. When we return back on this side, we may see that, for example, as I told, uterus here is written. If there is some abnormalities like disorders inside the cavity, or even fibroids, myomes, adenomyosis, or something like these, it may to some extent afflict the quality of endometrium. The hormonal status of the patient recipient or intended mother is really important, because if there is no normal concentration of estrogens and progesterone, we never reach the good quality endometrium, and the receptivity on some extent may be bad as well. And then the most important part, let's say, who afflict the implantation process, it's definitely the embryo. Only the good quality embryo with a good number of receptors on the surface of trophectoderm may be ready for the implantation. And I will ask Caroline to show us a video of a good quality embryo. Could you please do it?
Yes, of course. Let me show it to you. Here it is.
So you may see the embryo here is the first stage, so it was division before, first division, second division. You may see now 4 cells embryo. It's corresponding to 72 hours. You may see firstly 10 cells, now it's 96 hours was morula, and now it's expanded. Blastocyst, it's around 120 hours development of the embryo. It means that this embryo grow till blastocyst stage. This embryo perform the hatching process. It means that embryo go outside or peel from inside the shell that was remain from the egg. And this, like such quality embryo, will have good perspectives and good prognosis for the implantation. Okay, and so let's say that the implantation window and the best period for implantation will be in the middle secretory phase. It means that from 19th up to 24th day of the menstrual cycle is the best time to perform the embryo transfer. And in this phase, in this period of time, it should be the maximum concentration of estrogens and progesterone receptors inside the cavity. And of course, the embryo should be looking, as I showed you on the picture, on the video. It's real video from the Maritime Lives. So that embryo, if we put it inside the uterine cavity of the good quality, may produce, or it will be ideal to produce, a pregnancy. Definitely there is an internal fluids inside the uterine cavity, and the whole hormonal status and health status and many other biological active substances, as you may see on the screen, afflict the implantation process as well. So it means that there is not everything depends, mostly depends on the quality of endometrium, depends on the quality of embryo, but also organism of intended mother is under the regulation of internal hormones, depends on the immune status. So it means that everything should be under control. All hormones should be kept inside the normal range, and it shouldn't be severe deviation from the normal range in immune status as well. So the organism should be ready. And now I will like to show you one case report about one couple who suffered from infertility for several years. As you may see, this couple was a bit of the advanced reproductive age. The lady was 44 and her spouse was 46. They were suffering from primary infertility. Besides, the patient has uterine disorder like adenomyosis, and she was a poor responder. And the partner had poor quality sperm semen test. So it means that there was an indication for egg donation because of the poor egg quality. And it was an indication, as we know later, it was like retrospective information about the male factor. And it was not only the egg donation, it was actually the embryo donation program. The lady was a bit overweight. Her body mass index was over 25. Her hormonal status was compensated. She had hyperthyroidosis, but it was compensated due to hormonal replacement therapy. And the treatment history was as following. Several cycles with own genetic materials, both gametes, eggs, and sperm. After numerous, let's say 3 cycles, numerous unsuccessful attempts, even despite one biochemical pregnancy, the couple decided to go ahead and try to use donated eggs. 3 fresh egg donation cycles were done, and in all egg donation cycles, it was used the sperm of the husband. 2 cycles were without any kind of pregnancy, and just one lasted with a biochemical pregnancy. As a result, no clinical pregnancy, no child. From the last egg donation program, there was 1 frozen embryo transfer, and as well without any kind of success. After these, overall, let's say 7 unsuccessful attempts, the couple decided to use donated embryos. Donated embryos, overall, the couple had 4 false attempts. Only 1 biochemical pregnancy. And finally, from the last egg donation and sperm donation, it means embryo donation attempt, it was a successful clinical pregnancy. I will show you the uterus. So in this picture, it's a real picture of the patient, as I discussed, told you before about this patient, that her history was calculated overall 12 attempts, 12 IVF attempts, different types, own eggs, egg donation with the sperm of a husband, and finally embryo donation. And here on this picture you may see that there is almost no significant difference between endometrium and myometrium. The patient was suffered from adenomyosis. Her uterus was enlarged. It was round shape, and on some extent it was bulky uterus. And you may see that cavity was not ideal. It may be the explanation why she had so many unsuccessful attempts, even with the proven good quality embryos, because proven good quality embryos, definitely she had egg donation and sperm donation. And it was a preparation of endometrium, and the endometrium was about 9.5 and 11 millimeters. The thickness was good, but the paternity, you may see, you cannot see the clear triple line. You cannot see the measure between myometrium and endometrium as I shown you on a slide with the, let's say, normal, good endometrium and normal uterine cavity. But anyway, even in such difficult case for the reproductive doctor, it doesn't matter that pregnancy cannot occur. It was very difficult psychologically, mostly for the patient, to receive one false attempt after other false attempt, and this couple was really perfect. They don't give up. They go ahead, and finally they win. They become parents. So it's really important have everything good, or try to keep everything under control, and to go ahead to go and to try to keep trying. And that's probably everything that I can tell at the moment about the endometrium quality and endometrium and implantation window. And now I will be happy to answer your questions, if you don't mind.
Perfect. Thank you so much, Dr. Nataliya, for the presentation and giving us some tips on the implantation window. And now it is time for our Q&A session. We have some questions from our patients ready. So let me begin with the first one. Would you recommend DNA fragmentation even if sperm analysis has shown no issues?
Thank you very much, Luisa, for your question. You know that sometimes DNA fragmentation or higher DNA fragmentation percentage may occur even in the normal sperm semen test. So it's better to do it. My answer will be yes, I recommend DNA fragmentation.
Perfect. Thank you so much for the question as well as the answer. And let me have a look at the next question for you, Dr. Nataliya. This is it. Would you recommend antibiotics and or blood flow enhancers to facilitate implantation? No specific implantation issues, but clinic seems to favor such procedures.
Daria, thank you for the question. So antibiotics, let's start from the very beginning. Antibiotics will be recommended in case you definitely have some problems with microorganisms, or you have even benign inflammation into vagina or the cervical channel. It will be reasonable to start from the thyroid checkup. You should. It will be beneficial to have some tests, not only the pap smear that is routinely recommended, but also to take the vaginal culture and to take some specific tests, checkup for ureaplasma, chlamydia trachomatis, and so on and so forth in the cervix as well. And if there is a disbalance or even bacterious vaginitis, when it's vaginitis, it's definitely you should cure it. But even with the vaginosis, it will be beneficial to normalize the biacidosis into your vagina. Whether to use antibiotics or not, it's a question. If there is microorganism pathological or semi-pathological, yes, you should take antibiotics. If there is no microorganism, no inflammation, your leukocytes are within the normal range, and your pap smear show the normal test result, probably they should not be used.
Okay, wonderful. Thank you so much for the question as well as the answer. And let me move on to the next question. What is the role of progesterone in implantation?
Hello, Luisa. Thank you for your question. Probably it was a question about prednisolone or the glucocorticoid in implantation. We may use this sort of medicine definitely, because when we are talking about the egg donation program, it means that your embryo that will be implanted, this embryo has no genetic links to your organism. And to reduce your immune response, on some extent, it may be reasonable to take prednisone.
Okay, thank you. And let me move on to the next question. What do you think of the WIN test to find the right implantation window?
Hello, Emmy. Thank you as well. WIN test, or maybe you're talking about ERA test, when we're testing the estrogens and progesterone receptors inside the uterine cavity, may be helpful to find the implantation window. And sometimes it will be enough to postpone or to make a transfer just 1 day later or 2 days later, according to the test result. So your organism will be using progesterone for 1 or 2 more days, and it may be beneficial. It may bring its results, but it does not mean that this only thing will help in 100%. You know, the most important is have individual approach to each patient and to find what is the real matter of unsuccessful or implantation failure in each precise case. Sometimes it's enough just to give 1 or several days more progesterone. Sometimes we need to add something. Sometimes we need to change something in the general protocol. So it's definitely each method or each procedure or something that we develop, like scientifically we developed by this period of time, definitely it may be helpful in some extent.
All right, thank you so much for the question as well as the answer. And let me have a look at the next question for you. What about the mattress lab test?
So dear Amy, mattress lab test, could you please specify it a bit more?
Yes, if you could get back to us with some details, okay, we will just go back to this question for you.
Or probably we'll leave this test and this explanation for mattress lab via email as well.
It's okay, of course, as well. Thank you. And in the meantime, let's have a look at the next question. Would you recommend doing a repeat ERA after an ectopic pregnancy? First ER mapping was done in November, and I will be transferring in June.
Dear Amber, thank you. You see, ERA test shows really the concentration, as I told previously, the concentration of estrogens and progesterone, and the best time for implantation. When we are talking about ectopic pregnancy, let's say if your ERA test was positive, it should not be so if your ERA test was positive and your implantation occurred on that precise time, or at the time of the embryo transfer that you had previously, or first time that lead to ectopic pregnancy, it doesn't mean the next time it will lead to ectopic pregnancy as well. You know that ectopic pregnancy, it's a complication of embryo transfer, possible complication of embryo transfer. And it actually does not really related to the ERA test. If ERA tests show you that on this precise time, let's say LH peak plus 7 days or LH peak plus 6 days, your uterine cavity is ready to percept an embryo, it should be the same this cycle and next cycle and 2 cycles in ahead. So probably you should not repeat the ERA test if the first one was positive. If the first test just show you that your lining is pre-receptive, please repeat the ERA test until it will show you that this time is the good receptivity. Or if your ERA test shown you that you was post-receptive, definitely the embryo transfer should be done earlier. Or if you want to prove that you're on the correct way, you need to repeat next cycle the ERA test to find the best time, to find the result that at this precise period of time, your endometrium is receptive.
Perfect. Thank you so much. And we have a similar question. It's about what is your opinion in general on ER map test?
As I told probably previously, hello Sandra, thank you for question. You know that every test that we are using is good for some reasons. And if your doctor just prescribe you this test, it means that by means of the test, a doctor likes to prove or to exclude some kind of pathology and find the best option for your couple to figure out some problems inside the organism and to prepare the couple in the best way for the further IVF attempt. Nobody wants to receive the kind of unsuccessful attempt. Doctors are suffering as well, not only patients. Patients are suffering that there is no pregnancy, and doctors are suffering that there is no successful pregnancy in this precise case.
Thank you so much again. And we have another question regarding the ERA test. Let's have a look at it. Would you recommend doing ERA test if I only have 3 days frozen embryos and not blastocyst?
Hello, Lilia. Thank you. Let's say it's reasonable to do the ERA test to find the best day for the possible implantation. When you have the day 3 frozen embryos, you have actually 2 possibilities. The possibility number 1, thaw embryos on day 3 and let them grow in laboratory until day 5, until the blastocyst. And this blastocyst stage of the embryo should be corresponding to the positive ERA test to the implantation window. If there is no possibility to make culturing of these embryos till blastocyst, but we can presume that your embryos will be alive after thawing and your embryos will be developing inside the uterine cavity, we need to make a transfer according to the calculation when exactly your embryos will reach 120 hours, it means day 5 or the blastocyst stage, and this possible blastocyst stage should be within the implantation window proven by the ERA test. If both positive ERA test day and the transfer even of the day 3 embryos sewn, and then we calculate that it should be like these, are corresponding to each other, it may be successful pregnancy as well.
Perfect. Thank you so much. And now we will go back to the previous question. Okay, here it is about Matroy's lab. So it helps find if there are natural killer cells in the endometrium.
So, if there are increased natural killer cells in the endometrium, in the literature described, or sometimes it may be like Kier tests, in the literature described several things. There are articles on the one hand that it may flick the implantation window, but mostly on the latest, let's say, retrospective research, there is a data that increased natural killer cells inside the endometrium afflict the recurrent miscarriages. So the women become pregnant. It is even clinical pregnancy, but on some extent, this pregnancy may terminate on different stage. But mostly they are terminated after 10 weeks of gestation. It's a problem with the increased natural killer cells inside the uterine cavity. So the implantation will occur, or mostly will occur, but it may terminate afterwards.
All right, perfect. Thank you so much for explaining this to us as well. And let me have a look at the next question from the list. Here it is. What does it depend on if someone has a triple lining in the cycle or doesn't have? Does it mean that endometrium is receptive?
Hello, Beata. Thank you for a question. Sometimes some patients really don't have any kind of triple line endometrium. And this means that pregnancy may happen, but the percentage of successful pregnancy in such kind or in such category of patient will be much more lower in comparison to the group of patients with normal trilaminar endometrium.
Okay, perfect. Thank you for this question as well as the answer. And let's have a look at the next one for you. Would there be an option? I am quite allergic to utrogestan, but put inside uterus. Cannot tolerate it orally as it makes me very dizzy, tired. Reaction feels like urticaria, which I have. Type continuous itching, and I wonder if this could impact implantation.
Hello, Susanna. Thank you for your question. You see, we have several kinds of progesterone. And definitely when we're talking about IVF program, or when we're talking about, let's say, IVF programs, does not matter with own eggs or with donated eggs, we need to have a good support of the luteal phase. And you know that utrogestan is not the only option to support it. We have several kinds of medicine, and we have several routes to intake this progesterone, to substitute internal progesterone into your body. If you're allergic on utrogestan, you may change it to Crinon gel. It's one option. Or, for example, there is a lovely medicine, mostly in the UK, like Cyclogest. It has two major routes of administration, vaginally and rectally. So you may try to use it rectally. Or we have good number of intramuscle or subcutaneous progesterones as well, like Geston or Aglutin intramuscle route, and for example, Prolotex may be subcutaneous route. So your doctor will select the best option for you and definitely will substitute utrogestan on some extent. Without the support of luteal phase, with progesterone without adequate concentration of progesterone inside the uterine muscle, it's hardly possible to imagine the good prospective progressive pregnancy.
Okay, perfect. Thank you so much for this question. And let me see, there is another one. Do you recommend DHEA during assisted conception procedures and probiotics throughout the procedures?
Good evening, Justine. Thank you for your question. The epiandrosterone is recommended in patients who have low concentration of DHEA inside the body. And probiotics you can use as well. There is no contraindications. But if you means about probiotics like local one to make, let's say, to make normal biogenesis inside vagina, it's reasonable to use them before on the stage of preparation, and then when you're in the procedure, continue taking probiotics like orally.
Wonderful. Thank you so much for this as well. And we do have another question. Here it is. Do you do endometrial tissue tests for microinflammation, and do you use antibiotics, doxycycline to cure it? What is your opinion on testing the endometrial tissue?
Hello, Sandra. Thank you for these questions. It's reasonable to make a tissue. Now, you're talking about the so-called endometrium biopsy and the, let's say, the investigation with the help of pathological testing when we're doing the sample on the glass and when pathologists just gave their solution, whether there is a kind of so-called chronic inflammation inside the endometrium or there is no. If there is a chronic inflammation process inside your cavity, it's reasonable to use antibiotics. And it should be wide spectrum or broad spectrum antibiotics. Not only doxycycline can cure this kind of inflammation. But to answer the question, if it's reasonable to check the inflammation, yes, it's reasonable. If it's reasonable to cure the inflammation with the help of antibiotics, yes, it's reasonable.
Thank you so much for the question as well as the answer as well. Let me see. We do have another question. Some studies talk about a positive role of presence of lactobacillus on the endometrium, cervical cavity, and digestive system for implantation success. Can intended mother take lactobacillus through diet to improve success implantation rates?
Hello, Judith. Thank you for your question. Actually speaking, the endometrium cavity or internal cavity should be clear from bacteria. It should be lactobacillus inside the vagina. Yes, it's good. And it should be normal concentration of this lactobacillus inside the vagina. So it should be balanced. You should not took these bacillus inside the endometrium or inside the endometrium cavity. And definitely you may take lactobacillus or you may take probiotics orally, but the most important is a concentration of probiotics not in your guts but mostly in your vagina. And there are some sort how to increase the lactobacillus inside the vagina.
Thank you so much. And let me go ahead with the next question. Sorry, that we had already. So let me go to this one. What would you recommend to improve lining thickness? Thank you for your responses.
Dear Luisa, thank you for your questions. There are several, let's say, several ways that we can do on the way to improve the endometrium thickness. We can change the concentration of estrogens inside the body. It means that the dose of estrogens should be adjusted. It may be adjusted by several routes of administration of estrogens into your body. So it depends on the initial thickness of your endometrium, and then we need to see how it will be or whether it will be changed. Then we may try to improve the vascularization, because vascularization it's very important, makes very important role in the development of endometrium. And then we need to finger up and to work with some sort of, let's say, the thickness of your blood. It means for the better flow of your blood inside these vessels. So we have some arsenal of medicaments that could change the endometrium thickness on some extent and could be helpful on some extent.
Thank you so much. And we have a few questions left. So let me go ahead. Okay, we do have another one here. I have a history of poor lining. Donor egg blastocyst transfer failed. A lining was 6.7 millimeters, only one egg left, and I'm worried now it won't work. Was taking 200 milligrams daily of estradiol patches and a Fermotab. Would you recommend anything before next transfer?
Hello, Caroline. Thank you for your question. I understand your words about the endometrium lining. 6.7, probably you had some previous history of some inflammations, or probably you had some previous history of some manipulations inside the lining that may afflict it. By the way, 6.7, it's not extremely poor endometrium. Estradiol patches, we plus Fermotab, different route of Fermotab. Plus, probably it will be reasonable to add some medicine that will help in vascularization process. And even with these, you need to see how it will be growing and development. It's really very interesting to see your lining and the thickness of your lining in completely natural cycle without any kind of estrogens. Before the embryo transfer, you may try to do some sort of intrauterine insignificant injury to change the developmental process inside or reparative process inside your endometrium cavity. So probably it will be reasonable to think about endometrium scratching if you did not do it. And to start to adjust the dose of external patches and transdermal and oral medicine. Probably some vaginal route of taking medicine may be helpful as well. And beside this, not only depends on the lining. If you had embryos without the implantation, and this is only one left, probably next time, if you decide to go ahead with the IVF process, probably it will be reasonable to check the genetics of your embryos as well. The whole chromosome count of your embryos, it will be reasonable to do along with the preparation and good preparation of your lining. Sometimes with such kind of lining as you have, probably it may be helpful to do several cycles of estrogen support before you will do the transfer of your embryo. You should think about all of these, discuss it with your doctor, and finally find the best opinion how to do and how to continue.
Perfect. Thank you so much for this question and advice. I believe we have 2 more questions and we will be finishing. So let's get ahead with it. On which days of the cycle should the biopsy for the chronic inflammation test be performed?
Dear Sandra, there is no difference when we're talking about chronic inflammation, whether the inflammation will occur or not. So the best time in this case will be to finish with the menstrual bleeding and try to do hysteroscopy or just try to do the endometrium biopsy in the first part of the menstrual cycle to try to collect the endometrium, one sample of endometrium functional, and probably on some extent it will be possible to pick up a small part of the, let's say, basal layer of the endometrium, which should show the inflammation.
Thank you. And I believe that will be our last question. But if you have any other question, just go ahead and type them all in. And let me show you this one. If the ERA test shows post-receptive, exactly, do I need to repeat the test, or is it enough to transfer 1 day later, 1 day of progesterone supplementation more?
Dear Sandra, post-receptive, it means that you should do the transfer 1 day before. You should repeat ERA test, or you should do blind transfer 1 day before the previous attempt. When you've done the ERA test, it means that your ERA test was on the same cycle that you used before the embryo transfer, or on the cycle with embryo transfer, the same amount of estrogens, the same amount of progesterones, the same protocol. And now you need just to calculate on which day of your menstrual cycle this ERA test was performed. And from this you have several options. Whether to try the embryo transfer 1 day before, you've done it in previous time, or to repeat the ERA test 1 day before you've done the previous time. That's it. In your case, probably it will be enough 5 days of progesterone intake or 4 days of progesterone intake before the embryo transfer. It's very individual. Post-receptive, it means that you put the embryo when there is no implantation window, where, let's say, if it's possible to say like this, when this window was closed. And you need to put your embryo when your implantation window is open.
Perfect. Thank you. Sandra has added something just now. Sorry, the ERA showed I was perceptive on day of the biopsy.
So pre-receptive, it means that you need to do opposite. You need to do it whether 1 day before or after, or 2 days after. In my practice, I had patients with pre-receptive endometrium, and mostly, generally, it was enough to put embryo just 1 day after, and it was it. But sometimes, in rare cases, it was that next day, when we presume that it's not enough, we'll continue for 1 more day with progesterone. We repeated ERA test, and it was pre-receptive as well. In those cases, probably we need 2 days more and repeat. So it depends. Better to repeat the ERA test 1 day after the previous attempt and then see whether it will become receptive or not.
All right, perfect. Thank you so much. I don't see any other questions, so I guess we will be finishing. But if you have any other questions, just go ahead. And plus, let me remind you that you can also forward your questions to patient@eggdonationfriends.com, and we will be able to forward them to Dr. Nataliya, and I'm sure she'll be able to get back to you. All right. So again, let me thank you all for joining us today, for all of your questions, and of course, Dr. Nataliya, for your presentation, for your time and expertise. And is there anything you would like to add?
So it was pleasure to stay with you tonight. Thank you for questions very much. I'm open to answer your questions if you have. Please send them via email.
Thank you so much. Okay, have a good night, everyone. And remember, you are able to watch our webinar tomorrow on our website. The link you will find in our chat section as well. You can also subscribe to our YouTube channel, and you will be up to date as well. Thank you all. Have a lovely night. Bye bye, and hope to see
Thank you.
you next week as well.
Bye bye.
Thank you. Bye.